Hello, my name is Quentin Davis, and today I'd like to tell you about our work in trying to predict which subjects with diabetic retinopathy will need an ocular intervention using retinal function information, namely ERGs and pupil response, as well as structural information, namely fundus photographs. I work for LKC, the manufacturer of the RETeval device used in the study, so I have a conflict of interest. The other authors don't have a conflict of interest. These results were published in August in TVST. So in 2013 and 14, we had a diabetic retinopathy trial where we looked at 467 subjects that were selectively recruited to form an even distribution of diabetic retinopathy severity. So this distribution created more subjects with advanced disease than you would find in a normal population. They were tested with the RETeval device and with 7-field stereo ETDRS photographs that were double read and adjudicated to make sure we had solid photography information. It was done at 2 sites, an Oklahoma City and an Atlanta Veterans Administration Hospital, and this study used the subjects from the Atlanta VA. In 2017, a chart review was performed on the 268 subjects that had data available. In that chart review, we looked for ocular interventions resulting from diabetic retinopathy, namely vitrectomy, injections, and laser. And the author who did that chart review was blinded to the results from the original study. Then, the photographs and the RETeval results, as well as his ocular interventions, were combined in a survival analysis, namely Kaplan-Meier and Cox proportional hazards. In terms of demographics, we were primarily African American and Caucasian, and because it was a Veterans Administration hospital, we were primarily male. In terms of disease status, about 20% of the subjects had clinically significant macular edema, and in terms of retinopathy level, 15% had no retinopathy, about 25% had mild retinopathy, about 30% had moderate non-proliferative diabetic retinopathy, 15% had severe NPDR or proliferative diabetic retinopathy, and 15% were ungradable. If we plot the RETeval DR score versus the subjects that did not require an intervention, so 100% at the beginning of the trial, then you can see the results from the blue curve of 1 year, 2 years, and 3 years after the initial measurements of what percentage did not require an intervention. So as you can see that an increasing DR score led to an increasing probability of needing an intervention. In terms of structure, as you go from no retinopathy to mild to moderate to severe to PDR, you also have an increasing likelihood of having intervention as you increase the DR severity. One issue, though, is this ungradable rate. So those 15% of the subjects had only an intermediate level of needing an intervention. In fact, this level was only slightly greater than the baseline probability. The RETeval DR score is comprised of 3 measurements. One is this flicker implicit time, where as the time gets longer, you have a more likelihood of needing an ocular intervention. It also is comprised of an amplitude, a flicker amplitude, where a decreased amplitude increases the likelihood of needing an intervention, and a pupil response. So unreactive pupils or unresponsive pupils are also indicative of needing an ocular intervention within the next 1, 2, or 3 years. And the DR score combines these 3 pieces of information to generate an overall score. The color coding here shows the reference data that's in the RETeval device. So this red zone is the upper 2.5 percentile in time, or the lower 2.5 percentile in amplitude or pupil response. So you see subjects that are outside the 95% reference interval are the ones who are most likely to need an intervention. In terms of a binary criteria of will you need an ocular intervention or not, we looked at 2 structural criteria and 1 functional criteria. The first structural criteria was, did the subject have severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy? And this will be abbreviated in the talk as the early treatment diabetic retinopathy study, diabetic retinopathy, positive or negative. The second structural measurement is whether they had that first measurement of severe NPDR or PDR, or if they had clinically significant macular edema. And this will be abbreviated as vision-threatening diabetic retinopathy, positive or negative. And our functional measure is whether the RETeval DR score is greater than 23.5. And that would be abbreviated as RETeval positive or RETeval negative. And ungradable results are also considered positive. These are Kaplan-Meier statistics plots going from 0 years to 3 years after the initial ocular exam. And this is plotting the percent without an ocular intervention. So everyone starts out at 100%, and then this black line is the a priori function, same on all three plots for before the test. So about 15% of subjects had an ocular intervention in the first 3 years after the study. If you were RETeval positive, you had an increased risk for having an ocular intervention, and if you're RETeval negative, you had a decreased risk. Similarly, if you look at the structure, vision-threatening retinopathy, if you were positive for vision-threatening retinopathy, you had an increased risk. If you were negative for vision-threatening retinopathy, you had a decreased risk. If you ignore clinically significant macular edema and only look at severe NPDR or PDR, you had an increased risk if you were positive and a decreased risk if you were negative. And all three of these are statistically significant. If you look at the ratio of the slopes of those, you can compute the relative risk, where the relative risk for being RETeval positive is 11-fold. So you're 11 times more likely to have an ocular intervention if you're RETeval positive than RETeval negative. If you have vision-threatening retinopathy, you have a 4-fold relative risk, and you also have a 4-fold relative risk if you have severe NPDR or PDR, ignoring your clinically significant macular edema status. These error bars are rather large, so they aren't statistically significantly different from one another, although they are all statistically significantly different from one. But if you were forced to choose one, you would always choose the biggest one, which was the RETeval score. So how big are these relative risks? Well, I was trying to think of what's the biggest relative risk I could think of, and it was lung cancer with smoking. So if your current smoking status is that I'm currently smoking, then your relative risk is 8-fold higher for lung cancer if you're female and 24-fold higher if you're male. So 8-fold would be here, 24-fold would be here. So that's kind of comparable to this RETeval score. So that means that the RETeval gives you just as high relative risk for needing an ocular intervention as smoking does for lung cancer. So that's a really big risk. Instead of looking at time on a continuous scale, let's just look at 1, 2, and 3 years, and flip this around to, instead of being the percent without having an intervention, percent with an intervention. So they all start out at 0, and then as time goes on, there's an increased chance of having an intervention, and there's also an increased chance if you're positive for the score. Here I'm plotting the photography score, severe NPDR or PDR. I didn't include clinically significant macular edema because most large-scale efforts don't include that measure. So what's the effect of adding a RETeval score to a fundus photograph? So suppose that you were fundus photography positive here, and you had a positive RETeval score. Then wow, that really increased the risk. So you went from about 25% chance at 2 years to 60% chance of having an ocular intervention. Or 1 year post the measurement, you went from having about a 15% chance to a 30% chance, a doubling in your risk. At 3 years, your risk is over 80% if you're positive for both. Now, if you're photography positive but RETeval negative, look, your risk is actually maybe even a little slightly below the risk if you were photography negative for both the 1 year and 2 year data. At 3 years, RETeval didn't quite reduce it maybe all the way to photography negative, but in the first 2 years, RETeval results have a profound effect on prognosis. What happens if you're photography negative? If you're photography negative and RETeval positive, well look, this is about the same level of risk as if you were photography positive for both 1 year and 2 years post the ocular exam. At 3 years, the RETeval didn't quite, wasn't statistically significantly different from a RETeval positive to negative. But at 1 and 2 years, the RETeval being positive with photography negative increased the level there, and being negative for both tests might have a small decrease in the risk. What about adding fundus photographs to a RETeval score? Let's turn it around and do the RETeval test first. Suppose you were RETeval positive and photography positive. Then that increases the risk. And what happens if you're RETeval positive and photography negative? Well, that decreased the risk, but not all the way down to the same level as if you were RETeval negative. And this is true at 2 years and 3 years, where photography modulates the relative risk from being just RETeval positive. At 1 year, photography did not change the prognosis. What if you're RETeval negative? Well, if you're RETeval negative, being photography positive or negative didn't affect results at either 1 year, 2 year, or even 3 years. Clearly there's no difference here, and this difference isn't statistically significant. So in summary, 268 subjects with diabetes were followed longitudinally for 3 years. Baseline measurements of 7-field stereo ETDRS photographs and RETeval flicker ERG and pupillography were measured, and then their effect on the probability of intervention was assessed. The RETeval DR score and the photography were both predictive of the subsequent need for intervention, although the RETeval DR score was probably a little more sensitive. The combination of both the structural and the functional were more predictive than either alone. And this is a separate data set than last year's results presented at Seoul at the ICEF meeting, with confirmatory conclusions on the efficacy of the RETeval DR score. Thank you.